All right, so NAGMAs, so non-alcohol, non-alcohol, non-anion gap metabolic acidosis, right? So we have a metabolic acidosis, but the anion gap is not elevated. Why is it not elevated? Because I did not build up acids. The acid level is 0. So 140 minus a bicarb of 24, let's say, minus a chloride of 104 is about 12-ish, right? But if I start gaining chloride, or I start gaining losing bicarb, which will then raise my chloride, that will then cause a metabolic acidosis because I'm losing bicarb, right? So it's due to a loss of bicarb or due to a buildup of chloride. Those are the key reasons why we have not a NAGMA, a non-anion gap, or normal anion gap metabolic acidosis. So what are the causes of this? It's because of a slow hard ass. All right, so what is that? So the mnemonic is H for hyperalimentation. That's another fancy way of saying TPN, right? So someone gets TPN. TPN has acids in it. It has phosphate in it. Also, when you give TPN, you give carbs and lipids. Your body's going to break down the carbs into CO2 and water. CO2 is carbonic acid, and the lipids get broken down to ketones slowly, right? So that's also, this causes CO2 and water production as well, but that's an acid production slowly over time. So you're going to start utilizing bicarb to neutralize all those acids. Therefore, the bicarb goes down, that's going to cause a drop in my anion gap. Okay. And then what else? Addison's disease. So Addison's disease is an endocrine disorder. We'll talk about more in endocrine, but it's an endocrine disorder where you have to add steroids to fix it. So Addison's disease is a lack of steroids, a lack specifically of aldosterone as well. All right, so you can think of low aldosterone. What does aldosterone do normally? It gets rid of potassium, right? So if I can't get rid of potassium because I have Addison's disease, I have hyperkalemia. If I have hyperkalemia, that's going to cause acidosis. Well, I thought hyperkalemia was over on the HAGMA side. That was like acute elevation in potassium. This is like a slow hard ass, right? There's a slow buildup of acids over time, a slow utilization of bicarb, and therefore I have a NAGMA, a normal anion gap metabolic acidosis. Okay, and then R for RTA. So RTA is not going to spend too much time on, but it's a renal tubular acidosis. So we're developing acidosis systemically because of one of 4 reasons in the kidneys, right? The kidneys are either not getting rid of hydrogen ions, therefore hydrogen ions are building up. That's actually type 1. Or we can't reabsorb bicarb in the tubules. That's actually type 2, right? Or we can't excrete hydrogen and potassium, which is the job of what? Aldosterone, right? Aldosterone's job is to get rid of potassium and by result hydrogen in the distal convoluted tubule, right? So that's another reason why we might get a renal tubular acidosis. So we have bicarb wasting over time is what's going on with renal tubular acidosis. And then a little more about renal tubular acidosis. You can figure out what kind it is by measuring the osmolar gap of the urine. So not of the serum like we did with toxic alcohol ingestions. We're actually taking the urine sodium and the urine potassium, which is sometimes used with osmolar gaps, and the urine. What else? And then we can see if there's a change in the gap there. Okay, because ammonia is very, very osmotically active, and only one renal tubular acidosis causes ammonia secretion in the urine. All right, going back to our mnemonic. So D for hard ass, or for diarrhea, right? So we have diarrhea. Slowly over time, we're losing bicarb. And what happens? The chloride will try to neutralize that. And that slow loss of bicarb causes a slow metabolic acidosis, therefore a reduction in our bicarb. Not a buildup of acids, but a reduction of our bicarb. And then acetazolamide. So acetazolamide acidifies the blood. And sometimes we do give that for patients that have a contraction alkalosis or metabolic alkalosis. But for this patient that's just getting acetazolamide without a good reason, it can cause a buildup of CO2, and that will then use our bicarb slowly, right? Because CO2 buildup causes carbonic acid production, and therefore bicarb will neutralize it and cause a reduction in bicarb. And then saline, as we talked about many times. So saline is going to introduce a whole bunch of chloride. So you can see here, all this chloride elevation cause a dramatic reduction in bicarb, right? Or acidosis. And then spironolactone. Spironolactone is what kind of diuretic? So potassium-sparing. So that means hyperkalemia. So hyperkalemia is going to be if it's over time, it's going to cause acidosis and neutralize our bicarb and therefore cause a NAGMA. Okay. There's other reasons such as like decay resolution. Over time, we're using all of our bicarb up because of the acidosis. That can cause a NAGMA. And then renal insufficiency. This is like a CKD patient, not like acute kidney injury. They're coming to the hospital like with complications. It's over time they can have a non-anion-gap or normal anion-gap metabolic acidosis. So how do you fix this? Of course, underlying cause, but we got to help the kidneys out. And we help the kidneys out by giving a bicarb drip or PO bicarb with Citra. And that's going to provide the bicarb that's being utilized all the time with all these reasons for acidosis, right? And then K-wasting diuretics, not K-sparing, are good options, right? It's called Diuresis. That's going to get rid of extra potassium, which could be contributing to acidosis, right? And then what else? So if they have hyperchloremic metabolic acidosis, we should probably stop that with, stopping the saline, right? If they have increased work of breathing, that could be a sign that patient might be deteriorating with metabolic acidosis. Right? So NAGMA, you might think is not as critical, but it can still cause a lot of problems. Okay, so that's the idea behind a NAGMA, right? We have things that will kill you with HAGMAs, and we have hard S's with NAGMAs. So metabolic alkalosis. So we're switching gears from HAGMAs and NAGMAs and acidoses and toxic alcohol ingestions all the way to metabolic alkaloses, right? So now our pH is how? Is up or down? It's up, right? pH is greater than 7.45. Our bicarb is elevated, not like a respiratory acidosis where the bicarb is compensating. There's a bicarb that's going up and up and up because we are vomiting, losing hydrogen ions, right? We have an intermittent suction causing us to have a loss of acids and therefore a buildup, a increase in bicarb concentration, right? Hypokalemia. If hyperkalemia causes acidosis, hypokalemia causes alkalosis, right? So that's a quick way to figure it out. But also steroids. So steroids do what? They raise what in the bloodstream? They raise the 3 S's. What are the 3 S's? Sugar, salt, and sex. So sex hormones go up, salt goes up because it mimics aldosterone at high doses, and also the sugar goes up because it's breaking down sugars, right? So salt goes up, and I have aldosterone excess is mimicking our. Why is the salt? If the salt goes up, that's because of aldosterone function, and if salt goes up is in the serum, that means I'm exchanging what? Salt for potassium, right? So salt and potassium are K is going into the urine and sodium is going into the serum, right? So we're losing potassium. That's hypokalemia. Excessive diuresis, we're losing a lot of potassium because we've given a whole bunch of loop diuretics, which are inhibiting potassium absorption, and therefore potassium is lost. So therefore I have a hypokalemia from too much diuretic use, right? And as we mentioned, we get contraction alkalosis because the bicarb concentration is now going to go up. If I'm losing all kinds of volume with diuresis, the bicarb concentration was 25, but now that's 25 MQs per liter. But if the liter goes down, right, that's going to be more bicarb per liter. So contraction alkalosis happens with excessive diuresis and also hypokalemia itself, right? What else? So chloride depletion. So if chloride goes down, what has to happen? We have to maintain our strong ion difference. Chloride goes down, bicarb is going to go from the cells into the serum to neutralize, right, to maintain ion balance. So chloride will happen in hypovolemia as well. All right, so we mentioned diuretics as a really common cause, especially in the hospital, of developing metabolic alkalosis. We have acetate. Where is acetate found? It's found in TPN. So TPN is made of a whole bunch of nutrients, and it's also made of acetate and chloride. So it's pharmacy's job to adjust that. They look at the numbers, they look at the electrolytes, they look at the chemistry, they look at the level of acidosis, and they'll either change the acetate or they'll change the chloride. As you know, if we increase chloride with normal saline, that's going to cause metabolic acidosis, right? If we increase acetate, which is converted to bicarb, which is, it neutralizes acids, right? increase acetate, we neutralize more acids. That's going to cause metabolic alkalosis. So adjusting those two will, hopefully prevent metabolic alkalosis or metabolic acidosis, right? Which one does TPN usually cause when you give it? It usually causes metabolic acidosis because all the carbs and lipids get neutralized into CO2 and water and cause a chronic utilization of bicarb. But why is TPN in both areas? Because usually it's our fault. Oops, I put too much acetate. Sorry, right? That's what usually causes the metabolic alkalosis in that situation. Citrate's found in blood products, right, and neutralizes calcium, but it also it's also a alkali. It's also going to neutralize acids, causing a metabolic alkalosis, right? Plasmapheresis uses a lot of citrate, and just bicarb. Someone ingests too much bicarb, someone has bicarb drip that's infusing, and no one's paid attention to the bicarb level. That's going to cause a metabolic alkalosis. Another oops. Okay, what else? So chronic hypercapnia, right, is not a reason for metabolic alkalosis. It's a compensation, just to point out that your CO2 goes up and up and up. Our kidneys are going to hold on to bicarb over time, and it's going to cause a alkalosis that's going to neutralize that CO2 buildup. But what happened, the reason why I bring it up is because sometimes we get overzealous with the ventilator and we change the respirator to like 24, 26. We blow off all that CO2 on someone who's been compensating all their life, or the last 6 months at least, right? So it can cause a metabolic alkalosis if you blow off too much CO2 on the ventilator. So how do you fix this? Again, underlying cause is a good answer. And here it is. It's time to shine. All right, you have contraction alkalosis, you lost too much volume, you vomited so much hydrochloric acid, we need to make someone acidotic again. There it is, normal saline. That is the answer to someone who has a metabolic alkalosis who's also volume depleted, right? If they are hypovolemic, you can't give normal saline anymore. Oh, it was short-lived. But normal saline was able to be given if you're hypovolemic. If you're hypervolemic, you still need to get rid of volume because I still want to diurese somebody. I need to give something that's going to make someone seat on the toilet and pee out urine that has potassium or doesn't have potassium. Do I want to get rid of potassium or I want to hold on to potassium? I want to hold on to it, right? So Acetate was our mnemonic for spironolactone and plerixafor, and we have our amiloride and triamterene. Those are our four, there's a few other variants out there, but those are our four major potassium-sparing diuretics, right? And then treating low K and low MAG. Well, K is low. That's what caused my alkalosis. Why do I need to treat MAG? So magnesium is for its little man that's inside of every single protein channel throughout the body, but it's also in the kidneys, and it's what turns on the machinery so that potassium can be reabsorbed, right? So you can think of it like that. Also, it maintains gradients and electrochemical neutrality and such, and allows potassium channels to then open up distally. So, but magnesium should always be replaced before or after potassium. Before, so that the potassium channel can turn on and it actually work. Okay. If someone is actually, you've tried all the above, you can actually give hydrochloric acid. I couldn't find a picture over the internet, but it's something you can do. They have to talk to pharmacy to build it make it for you.